It is my pleasure to welcome you to our CCTST Community Engagement Core Speaker Series. This is part 2 of a fabulous series we have on housing as a social determinant of health. We started last week with Dr. Camilla Wood, and we have an exciting group of folks who will be talking to you today on this very, very important topic. My name is Lori Crosby. I have the pleasure of directing the Community Engagement Core of our CCTST or CTSA. I also have some other fabulous opportunities, such as helping with the faculty DEI plan, diversity, equity, inclusion plan, and co-directing innovations in community research and program evaluation. So it is my distinct pleasure to welcome you all today to this hour and a half jam-packed full of wonderful inspiration and ideas program that we have for you today. I'd just like to remind everyone, if you're not already a member, to please join our CCTST today. You get all kinds of benefits from joining. It takes probably 30 seconds to a minute to join. We provide technical assistance. We provide access to training opportunities, eligibility for funding opportunities. You get notification of great events like the current event. You also have a voice in shaping the future of clinical and translational research. And it also gives you access to this wonderful network of investigators and community partners who have similar and complementary interest and expertise. So we really encourage you to join. You can join that by checking our website, cctst.org. Our Community Engagement Core has really been working over the last 10 years to eliminate health inequities through community research, training, and partnerships. And you can learn more about our overall structure, activities, and events at our part of the website, which is cctst.org/community. All right, so I'm going to spend just a little bit of time telling you about a couple of upcoming opportunities we have before we get to the program today. The first is our Community Leaders Institute, where we have community partners, community advocates, and some folks from the medical center come together to really learn about leadership and to learn about how to use data in programs and how to leverage that to improve programs, the quality of programs, which also makes programs competitive for funding. So we hope that many of you out there have already been through our CLI or will take advantage and learn more. Again, check our website. In addition, we have some grant opportunities coming up that we want you to know about. We have our Community Health Grant Program, which provides an academic and community partnership up to $20,000 in funds. We have our Partnership Development Grant. So if you're a community partner, an academic partner just getting started and want to work together, we provide a $5,000 grant for an activity for you all to work together, such as a needs assessment. And then this year, for the first time, we have an Integrating Special Populations Grant. And the National Institutes of Health has a specific definition for what they call special populations. These tend to be populations that are underrepresented in medicine and research. And these populations, we've created a grant mechanism for communities or academic partners who want to focus a grant on a special population. A special population, just to give a couple of examples, might be pregnant women, it might be children, it might be youth with a chronic medical condition. So again, check out our website for additional information. Today, our program will feature 2 exciting components. The first is a keynote presentation from Ruth Ann Norton, who is CEO and president of Green and Healthy Homes Initiative. Then we will have some question and answers about her dynamic presentation. And then finally, we will have a panel discussion. And our panel will consist of some local leaders who are working in the housing industry. And this will include Nina Creech from People Working Cooperatively. We will have Nick Newman from Cincinnati Children's. And then it will be moderated by Dr. Andy Beck, who also works here at Cincinnati Children's in our community health effort. we will also, okay, just wanted to mention that we will also have Ruth Ann as part of that panel, so you'll also be able to hear from her. Last week, we started our housing as a social determinant series, and we also, during that series, gave out several awards. And so I just wanted to give another congratulations to our awardees. We had an Academic Community Partnership Research Award, and you can see that there were two
Can you all hear me? Did she freeze?
Yeah, Lori,
Yeah, I can hear
we
you.
lost you.
Yeah, it looks like it.
Lost Dr. Crosby, right?
Yeah, that's correct. Yep.
Okay. I wanted to make sure it was on me. Thanks.
We're going to just take a moment and allow Dr. Crosby to
Okay,
rejoin the meeting.
It is
Hi, Dr.
definitely,
Crosby.
yes, it is definitely a technology Tuesday for me. So I'm going to keep going though. We had two other awards. Sorry, my Zoom just kicked me right out of the meeting, but I'm back. So can we get the next slide, please? Okay. We had an integrating special population award. I hope you all can hear me. Trying to talk as loud as I can. I will put on an AirPod while I'm doing that. Awarded to University of Cincinnati Center for Excellence in Developmental Disabilities. We had a practice-based research award, which was awarded to the UC Internal Medicine Pediatric Clinic in partnership with the UC Department of Family and Community Medicine. And we had our Community Health Advocates Awards, which we named in remembrance of Dr. Anita L. Brentley. We had two folks win those awards this year, Jennifer Foster from who's in the community of Avondale, and Brian Wright, who is with Cincinnati Compass. So just a congratulations again to our awardees. All right. Stacy, I'm going to ask you, because of technical difficulties, if you can provide the introduction for our keynote speaker here, Ruth Ann Norton. Stacy?
I would be happy to do that.
Okay, great. Thank you.
Just give me one moment. And I'd like to take a moment to thank everyone again for joining today. Very excited to have Ruth Ann Norton, who is the president and CEO of the Green and Healthy Homes Initiative. She joined the organization in 1993 and has led its development into one of the nation's most effective and foremost authorities on healthy housing and its impact on the social determinants of health and racial equity. Ruth Ann is an expert on lead poisoning prevention, healthy housing, and the housing intersection of climate, energy, and health. Ms. Norton also directs GHHI's national strategy, policy framework, and services to advance housing as a platform for improved health, economic, educational, and social outcomes for low-income communities. She broadened the organization's mission by designing the GHHI comprehensive model in 2009 in partnership with HUD and the CDC, built on a framework of cross-sector collaboration that integrates lead hazard reduction, healthy homes, and energy efficiency interventions. In 2021, she led the development of the nation's largest hospital community benefits investment in healthy housing and has established a partnership with healthcare to fund a 7,000 7-city social determinants of health healthy housing demonstration project. Ruth Ann Norton is a leading voice in articulating the significant health, social, and climate benefits of weatherization investments. She is a member of the EEFA and an author and has authored several publications on energy equity, including the recent Leading with Equity and Justice in the Clean Energy Transition. Ms. Norton serves as a member of the EPA Children's Health Protection Advisory Committee, National Leadership Academy for the Public Health, National Council of State Housing Agencies National Advisory Group, the Ohio Asthma Council, and the Maryland Lead Poisoning Prevention Commission. So definitely a wonderful list of accolades. We're very excited to have her with us. And without further ado, I'd like to hand it over to Ruth Ann Norton.
Good morning, everybody, and sorry to put you through that torturous long and very nice and thank you introduction. Let me say what an honor it is to be with Dr. Crosby, Stacy, you, and the entire team at the center, and also to be on a panel that includes two organizations that I admire greatly, Cincinnati Children's and PwC. So I look forward to the discussion this morning. If you can go to the next slide, we will get to the framing of what I hope to do today, which is to really talk about what we are doing as one of the contributions of how we are measuring healthy housing work and against the social determinants and structural determinants of health and racial equity. And to introduce you, if you don't know, to the Green and Healthy Homes Initiative, we were actually founded in 1986 by 9 parents whose children were poisoned by lead and found themselves together in the intensive care unit while their children were being treated at the Johns Hopkins Health System. They determined to turn their sights outward to help improve the plight of children in Baltimore with regard to lead poisoning and to really address the twin tragedies of deteriorated housing stock and poisoned children. Over the last 30 years, we have expanded our work to include climate, energy, healthy housing, and equity. And today our vision is advancing the social determinants of health and racial equity through healthy housing. If you'd like to go to the next slide. And this is where we work in our active projects today. GHHI has actually worked in 48 of the 50 states. We haven't gotten projects in Hawaii and Alaska to date, but this is where we are actively working, conducting feasibility studies, pilot design, implementation, and groundwork in direct services, which I will talk to you about. But we serve as the health advisor to the Energy Efficiency for All network. We serve mayors and governors in technical advisory to advance platforms of an aligned, braided, and coordinated approach to housing intervention so that we also measure and move systems around health, and economic and social outcomes. And I'll talk a bit more about that. If you want to move to the next slide. So this is what I think keeps us all up at night, that we work in the field of healthy housing. The 30 million families that live in housing condition and have a normal that is something we need desperately to change. An expectation that likely where they live, their child will be poisoned. And as we know from recent studies, even the CDC's estimate of 535,000 children a year is likely an undercount coming out of a recent study of labs looking at blood lead levels across the United States, where a child lays their head down at night and whether or not they'll be able to sleep through the night comfortably, or if they will suffer from asthma and spend more time in the emergency room and less time in the classroom, and where they suffer from extreme heat and extreme cold that not only cost us in terms of energy consumption and dollars, but causes the structure of the home to be more likely to have chipping, peeling, flaking paint, to have more mold, mildew, and moisture and pest infestation. And also in the same 30 million houses that we look at through the American Housing Survey, families that face trip and fall hazards, and that is especially costly to our elderly. Our goal is to take this 150 billion plus of avoidable costs a year and turn that around into an investment opportunity to build better pathways for health and racial equity, and to be able to ensure that our children no longer are deterred in the classroom through impacts on brain damage, but will get to the classroom healthy, ready to learn, and attending class, as asthma is the #1 reason kids miss school. All of these impact, of course, wealth retention, abilities to get to work, intergenerational wealth transfer, and economic education and academic achievement. So I want to talk about what we are doing as one part of the nation's fabric to address healthy, energy efficient, and lead-safe housing. To go to the next slide. And in doing that, one of the things that we have helped to establish in our work with many partners across the country is to look at the business case. Not only are we looking, though, at the return on investment economically, but we're looking at that human investment in terms of access, pathway, and opportunity as equity measures, which I will touch on as we move forward. But as a baseline, I think many of us know that for every dollar we invest in lead poisoning prevention, we will get somewhere between $17 and $221 in economic return to state and local communities. That similarly, in investing in the asthma reduction and respiratory health triggers in homes can yield up to a $14 for every dollar invested, but have a tremendous impact on work attendance, school attendance, and long-term trauma. And fall preventions, we are looking at over $20,000 per participant annually. And actually later studies are showing actually $40,000 per participant, where we can prevent trip and fall injuries, avoidable trip and fall injuries in housing, especially for our older adults, but also for our children. And energy efficiency, which we are now expanding in our work to decarbonization and electrification work, can have significant impacts on wealth retention and stability of housing. And all of this taken into account and woven together as an integrated model can have significant outcomes that I'd like to look at here with you today. So let's go to the next slide if we can. We'll go. So a little background on how we work and how we approach this is we are built on a model of aligning services and funding so that we reduce duplications, that we work with a comprehensive assessment in housing that looks at human health, bringing the clinic to the home, and that structural health that has so much impact on our residents and folks in the home, and being able to align those services also to build a better, stronger workforce that can earn more, and to braid resources at the home level so that families are no longer hunting, whether they are 200% of poverty for weatherization or 80% of median income for lead or other factors. And in fact, yesterday at our event with the U.S. Department of Housing and Urban Development in Baltimore, they announced that they have reached agreement on one of the major advocacy points that GHHI has worked on for close to a decade, and that is cross-qualifying between Department of Energy and HUD programs. We are now working to expand that to programs from HHS, CDC, and EPA, so that families can have a uniform criteria for aligning housing intervention programs in their home. Also, by doing this alignment, what we know from our studies with the Center for Employment Opportunity is that contractors cross-trained in healthy housing work will start at wages about $4,000 to $8,000 higher than their peers, and they will have more sustainable skills over time that are available for the general marketplace. So it is an important factor as we move forward under the Justice 40 initiative in coordination with the federal government in workforce capacity and building contractors as part of the face of healthcare and housing. But this also allows us better to focus these efforts on training risk assessors, data collectors, educators, and contractors, and hire from impacted communities as a major equity investment, and be able to look at all of the environmental health impacts in a singly delivered intervention through a better coordination and better shared data platforms. So if you will go to the next slide. Just to talk about this and frame this a little bit. This is some pictures of a family, Laquan Young, who was an administrative assistant in the Baltimore City Police Department when we first began our look at how to better align the GHHI model. Ms. Young called our organization, as I say, I often tell people, she called on a Friday night at 7 p.m. and I picked up the phone, which can tell you a lot about my social life at times. But what she was looking for was assistance because she felt that she was going to lose her job if she did not get help about the situations regarding her housing and her son's repeated hospitalization. After talking with Ms. Young, who had been turned down by the Weatherization Assistance Program because she had mold and lead paint in her home, in other words, the health and safety issues had not been taken care of, she was turned down from the lead program because of the weatherization and mold issues in her home. She had sought 5 different opportunities to get help to address her son Dwayne's situation with asthma hospitalizations, which caused her to miss work in a job that she had otherwise excellent reviews. And so we brought the Align model to Ms. Young's home to address these hazards that included poorly working mechanicals, energy inefficiency, lead, and mold. And we applied the Green and Healthy Homes Initiative model. If you go to the next slide, what you will see is what we have now seen in over 750,000 homes in our partnership with HUD and partners across the country in applying this model. We were able to reduce the allergens and asthma triggers in the home, improve the home by increasing dehumidification and removing mold, bringing the house to an Energy Star level, improving its mechanicals and energy efficiency work, fixing simple things like gutters and downspouts that were contributing to the problem, and of course, removing lead-based paint. The outcome is that in the decade since that work, Dwayne has never returned to the hospital for asthma, to the emergency room or the hospital, has graduated from high school with honors, and has moved forward. Ms. Young not only retained her job, but she was promoted. She was able to establish a 401k savings account and a college savings account. And for the government, we were able to show and prove out cost savings of about 25% versus if they had done this as singly aligned interventions. And so this is the story of having an integrated intervention into the work. And again, as I said, by cross-training contractors and employing from the community, we have a major impact on workforce development. If you want to move to the next slide. So we've had some milestones over the course of time that have been important, and some of which I'll talk about today. The work of the Green and Healthy Homes Initiative and how we have been able to change the housing delivery system has brought us to a partnership with ProMedica, an Ohio-based Medicaid managed care and healthcare agency, where we are raising $100 million with ProMedica to align in 7 cities a health and racial equity measurement by creating holistically healthy housing in Baltimore, Chicago, Detroit, Cleveland, Toledo, Philadelphia, and Pittsburgh. And we are looking to really measure social determinants of health and racial equity independently, be able to hire from the community to fund the necessary workforce development. And in places like Detroit and other cities, implement that value of comprehensive assessment as a way to more effectively deliver the myriad of programs in a more effective and efficient manner. As was mentioned in the introduction, we were very pleased in 2021 to launch a $50 million hospital community benefit investment grant from the University of Pennsylvania Health System to address lead in housing. We've also been cited by the Center for Medicaid Services and the World Health Organization in 2021 as a national and global best practice. And we've launched just recently the nation's only pay-for-success outcomes-based financing project with Molina Healthcare in the Bronx, where GHHI and Northern Trust have invested upfront for outcomes. And then the work with NYSERDA, the New York State Energy Administration. And amongst this also, and we'll talk a little bit more, is our work on lead. And in Baltimore, where we have reduced lead poisoning by 99%, we have returned back $44.5 billion, according to Duke University, in economic return. But the big factor on that, as we think about social determinants of health, we think about racial equity, is how are we tagging dollars and actually ensuring that those benefits are returned back to impacted communities in improved housing condition, in employment opportunities, and long-term equity pathways. So if we go to the next slide. So some of the ways that we are doing this is working on housing upgrade benefit for seniors type programs across the country. They're called Stepping On in Cincinnati with our friends at PwC. We're doing a Capable Plus in Memphis, but really looking at best practices in fall prevention and other measures on age in place for older adults as a measure of healthy housing. It not only ensures that grandparents will be more accessible and in their home for their grandkids and to live a better life with health and dignity, but what it does also is it ensures that homeownership retains with the family, builds a better pathway to intergenerational wealth transfer, and ensures that we are able to lower the cost of healthcare and improve the health of our seniors. So we are a co-lead for the HUBS program in Baltimore with Civic Works, and tomorrow both the Secretaries of Energy and HUD will be at Civic Works to look at this and a number of integrated programs. We provide support and capacity services and evaluation services with our with people working cooperatively. A wonderful program that they have, and you'll hear more about in this panel. And in Memphis, we are serving as the evaluation partner between the Tennessee Department of Aging and Habitat for Humanity and Le Bonheur Health System to look at how do we use the Capable program but go deeper on housing repair to root causes, and what does that return in economic value for TennCare, for the Medicaid and Medicare programs. And we think this has enormous value, deeply personally invested in it myself, because my mother was someone who had a trip and fall hazard that led to hefty cost and eventually to her own decline, simply by measures that could have prevented those falls. So I think this is critically important, and it goes importantly to our lowest income communities, the ability to improve that generational wealth transfer as well, as we look at that as an equity measure. Do you want to go to the next slide? So as we develop these programs, go a little deeper, on the Penn Medicine Hospital Community Benefit Investment. And yesterday, we asked one of the largest health systems here in the state of Maryland to replicate this at $100 million for work in East Baltimore. But what the Board of Trustees at the Lancaster General Hospital and at UPenn really decided was that they could better use their hospital community benefit program and their investments to improve the long-term trajectory of the citizens of Lancaster by investing in its children. They looked at asthma, they looked at trip and fall injury, they looked at diabetes and other issues, but they landed on lead, not because they would create large health savings, but they felt that long-term, that was their best investment in the social determinants of health for education, for housing stability, for long-term earnings, and other factors that they felt that was their best investment. So we teamed this $50 million investment from the hospital up with a $10 million investment from the U.S. Department of Housing and Urban Development to create $60 million in money focused on lead eradication in Lancaster County. Through this work, we will fully abate 3,500 homes, but we're also focused on building the ownership of community-based contractors and through a local resident workforce in health education, in risk assessment, and data collection. And it will all be tied together through educational opportunities on lead prevention. And we will track through this school performance, housing stability, and economic outcomes as part of the evaluation. This is a 10-year program that LGH is putting in $5 million a year. They've also, at the Penn Health System, also invested $150 million in lead and water in the city of Philadelphia. So they really are moving not the issue of lead, but also on how they can move social determinants. GHHI serves as a project manager and an advisor to Penn Medicine in this project. If you want to go to the next slide. So in the ProMedica Social Determinants of Health program that I mentioned earlier, through the $100 million investment, which will go to workforce, comprehensive assessment, gap funding, meaning between the aligned programs in places like Detroit and Cleveland, Toledo, and others, where they bring together weatherization and lead and home repair programs, there's often a gap that is needed. And we've run programs for the state of Rhode Island and Maryland and other states where that identified gap is the difference between services being delivered or services being declined. For example, for weatherization assistance programs, if health and safety is not applied properly in coordination, about 62% of the time in major cities, weatherization is deferred or declined for the lowest income families. So in this program, we're looking to change the lives of 28,000 individuals, with 6,400 avoiding lead exposure with an economic value of $315 million, reducing hospitalization costs by $24 million, and improving the lives of our older adults and reducing that healthcare quotient by about $57 million. And through this, we will conduct energy efficiency, weatherization, and decarbonization practices, not only to support climate as a social determinant of health in the home, but also to improve the equity opportunities for families. And through this, we hope to create, and our projections show that we will create at least 714 new jobs working in 7 cities to advance this work, which begins in 2022 and will run through 2024. And the external evaluation will, through the ProMedica Impact Fund, will be done by a group called Socially Determined. Happy to answer questions more about how we're going to implement this. If you want to go to the next slide. So as we do our work in cities across the country, GHHI has worked in about 80 cities across the country, as well as working with state governments. We really are focused deeply in states like New York and Maryland, Rhode Island, Michigan, in building the service, and in Ohio, in building the service capacity for local service providers to build their strength. We come as an underneath girding support system in communities around the country. We help organizations think about operations planning to scale, how they can measure health and social outcomes, as well as racial equity. That may include looking at their cost factors in budgeting, building an evaluation program that not only shows outcomes of success, but building that evaluation so that there's a provable value to the health savings. We work with organizations like Newman on the projection side, but GHHI's team itself does patient health evaluation data for big states like Connecticut and New York and Maryland and big health systems across the country. We look at those valuation of those health outcomes and build a framework for return on investment. And that was critical for our work that we just launched in the Bronx on outcomes-based financing. And we provide data management services, and we'll also be launching in 2022 a University of Value, which is teaching service providers around the country how to do contracts through value-based purchasing outcomes and other mechanisms with Medicaid managed care, with Medicaid programs directly, and hospital systems. So if you want to go to the next slide. One of the core aspects of our work, we were founded as a social and racial justice organization in our work to ensure that African-American children in Baltimore could get to the classroom healthy, ready to learn, earn, and compete for a lifetime by eliminating the threat of lead poisoning. We have built on that in our work and measurement on our aligned broader platform. We build in that racial equity measurements in a project that we are doing jointly with the Bloomberg School of Public Health through their SOURCE program. We build on community voice. So important to us, and I know many of you, is listening to the barriers and to the recommendations of our clients on the ground level who are living and experiencing these barriers. Yesterday in Baltimore, we ran a 45-person listening session to receive feedback on how we are delivering services, how the federal government can better align for delivery, and where the core needs are. But we also look at patient health data, our own scopes on the work through the comprehensive assessment. And we take all of that data together in looking at metrics on economic outcomes, whether it's reducing cost for energy efficiency through consumption savings on utility bills, a parent's ability to get to work and to advance at work, lowering the cost and the opportunities cost from lead poisoning, asthma, injury. And also we look at things like housing stability and other aspects. In our studies that we have done for the U.S. Department of Housing and Urban Development, for example, in a study that we did looking at these global kind of measures on environmental health, we were able to improve for kids who are chronically missing school in Baltimore City, in a cohort of 240 houses, 139 children who were deemed as chronically missing school for asthma. We moved that cohort to 62% of those kids moving to perfect attendance in the 6 month and year after. Improvements in work attendance were 88%. Reduction in hospitalizations were 66%. These measures and our turnover rate, I should say, moved from 42% a year to 6%, really putting in place housing stability, better opportunities for work, school attendance, and long-term opportunities for savings, housing value, and earnings. So we look at all of that in a feedback loop and have built the systems to measure health and racial equity that we will be measuring in the ProMedica project, in the Lancaster project, and in all the work that GHHI does in its direct service programs in Baltimore and in Memphis. So if you want to move to the next slide. So some of the data analysis here, this is for one of the state Medicaid agencies that we are working with. We can't use their name yet because the report is about to come out and they will release the report. But what we have shown here is looking at reducing trip and fall injuries for an age in place program has shown an average increase of $40,000 in medical costs if we do nothing, right? For those who are experiencing that within 24 months, then the reverse of that savings happening by preventing this trip and falls. So this has actually shown a much higher opportunity for return in cost reduction than we have seen in previous programs. But I think this is really important that this is moving from sort of the occupational health and education model to the actual deep dive on the prevention of trip and fall injuries in the homes of older adults. So that $40,000 potential savings is pretty significant on a per patient basis. If you want to move. So some of the ways that we've used the payment models, one, here in where I sit in Baltimore, in our direct service program, we work with the Anthem AmeriGroup program to fund our asthma reduction services, where AmeriGroup will pay 75% of the cost after first visit and 25% after successful enrollment on 5 months. And we cover home education, supplies, home assessment, integrated pest management. We are now starting to do deeper dives. And recently in our second Healthy Homes Tech study that we have done, we have shown significant return on investment on that deeper dive with Anthem is looking to move to that is in future years to do home repair, a deeper home repair. But just on the baseline here, we've seen a very significant improvement in administrative funds. So we're in our third year funding renewal there and have expanded our work with Anthem and AmeriGroup across the country as GHHI has become a high trust audit vendor in their service provision. In Michigan, we worked with Priority Health to utilize contract with Healthy Homes Coalition of Western Michigan to satisfy the Michigan Medicaid requirement of MCOs to address social determinants of health and receive that 1% premium withheld. In New York State, we worked with the then Medicaid director, Jason Helgerson, to move to a model of mandatory investment by New York Medicaid in service providers like that perform interventions like GHHI in improving home repair and other service providers in working on other issues, and have utilized that to expand services also in New York and as a baseline for some of our work with the state agencies to promote health and safety in alignment with energy costs. We've developed similar models here for a number of states around the country, United in Texas, Le Bonheur Hospital and Erlanger Hospital in Tennessee, the University of Utah Health System in Utah, and Integra in Rhode Island, and UMass Amherst Amherst and Worcester in Massachusetts. So if you want to go to the next slide. So the project that we just closed in New York, I think, is really fascinating and will be another tool in the box for healthcare providers and health systems. And this effectively was the Molina Health System borrowing from the private markets to unlock Medicaid managed care work and outcomes as a post-COVID measure to improve indoor air quality, reduce asthma, and improve the health of housing. So through $4.85 million of investment from Northern Trust and the Green and Healthy Homes Initiative and the JPD Foundation, we will be able to serve close to 1,000 families in the Bronx and throughout New York City to lower the incidence of asthma, emergency room visits, hospitalizations that we know from the evidence built through 20 plus programs that we've done around the country with support from Robert Wood Johnson to prove out the measures on interventions to remove asthma triggers and the baseline of where families and kids will move. What is significant about this is that the loans to Northern Trust and GHHI are being repaid simply through and solely through savings created for the healthcare system and being returned. So at the end of, we'll do 4 years of services, we will do evaluation for 9 years. And at the end of that period of time, both loans, Northern Trust as a senior, GHHI as a junior lender, will be paid back at a rate of about 2% back, as well as, and most importantly, kids and families having health improvements, better housing stabilization, and other measures of retention on the health system to really redirect efforts to wellness here. And I think it's really an amazing model that Molina has done with GHHI and our partners. So if you want to move to the next slide. So I've kind of covered this. I'm sorry I jumped ahead of my slide here, but what I think is kind of significant here is the important partners that include the New York City Health Department, of the now Molina was previously called Affinity Health Plan. We are using 2 service providers in the city of New York, Air NYC and the Affordable Energy Group. And we're using the health department as an advisor and a financial intermediary. We'll serve 850 families, and we will create a total savings, we project, of about $6.5 million for the health system. They will walk away with a total net of close to $2 million, paying back all of the transaction costs and the loans. But in the end, it is about families being able to address these triggers in their home. If you want to move forward. I'm going to stop there. We can talk a lot of things. I'd love to get to the panel. I hope this has been helpful to give some real world examples around building on what you heard from Dr. Wood in your last talk, which was my intention. And look forward, Dr. Crosby, to answering any questions or moving to the panel.
Thank you so much. That was incredible. It was so amazing to see some of the equity empowered relationships and cross-sector work that Dr. Wood alluded to actually come to fruition in your work. It's amazing.
The answer is yes to slides. Please get them out.
Yes, it was great. So I would like to open it up to some general questions that people may have for you and your talk. And those of you who are on the webinar, please put them in the Q&A. You're in the, you're able to access the chat. You can also put your questions there. And someone's also already asking if we can have access to your slides. They said it was a fantastic presentation. Ruth Ann is shaking her head yes, so I'm thinking that's
So
okay.
Just as a measure, everything we do is open source, so we're happy to share with everybody. Apologize if I went over any time, and certainly love to get to the panel as well. So
Yes, we will definitely get there. Just wanted to make sure people had, if they had a burning question for one of the great efforts that you mentioned, because you mentioned so many that they might want to do it. I think we'll talk more about this as we get to the panel, but I just really appreciate the cross-sector work that you're doing and the alignment and integration and how significant that is to really achieving equity. I think it was just reinforced, like we sort of know that in our work, and Dr. Beck, who I'll introduce in a second to moderate our panel, really works in our community health effort, which is trying to do that. But this was just a reminder and an excellent example of how when systems come together and not only focusing on, I think uplifting the work, but also employing and investing in the community. Right, as by training, by providing employment, can really be an equity force. So
the three things I didn't mention that I just would like to throw out as we start this too. We are proposing to the Low Income Heating Assistance Program that they expand their home mod to include measures of climate and energy efficiency. We have seen such significant improvements in asthma when we work on the energy efficiency, ventilation, and indoor air quality piece, that not only is it economically important to stability, because we got into integrating energy efficiency on the sole fact that 23% of the families that we were serving, creating lead safe and healthy housing in Baltimore, were moving because of energy, right? And that was enough of a movement for us to start to integrate. When we did, we saw the precipitous decline in asthma go up, and Dr. Beck and others may be able to comment better on that. But another area that we are really moving is in the significant work that we've done through HSIs and using unused administrative dollars from CHIP to do lead and asthma. We are now building the evidence base for CMS and others to include energy efficiency, decarbonization, so removal of gas stoves and putting electrification, heat pumps and others, to be a measure that should be included in the available use of funds for CHIP, for LIHEAP. And in fact, we have a meeting coming up with CMMI, not to get too much out of the bag there, but we're going to propose that one of the innovations that CMMI ought to do through their innovation fund, Center for Medicaid and Medicare Services Innovation Fund, is this concept of whole house renovation around climate, energy, and healthy housing, and to include in that the equity measurements. So I'll leave it there. I see Dr. Beck. I'm excited to see you again, sir, and others. And I look forward to the discussion.
thank you so much. Thanks again. It is my distinct pleasure now to introduce Dr. Andy Beck. Dr. Beck is an associate professor here at the University of Cincinnati College of Medicine and attending physician at General Community Peds and Hospital Medicine at Cincinnati Children's. He received his MD from the University of Pittsburgh School of Medicine and his MPH from Harvard University. He's been here since residency, and his research really aims to equitably improve child health outcomes by addressing key social determinants of health. And he is one of the leaders in our community health initiatives, which strives to partner with the community to help Cincinnati's kids be the healthiest in the nation. And so I'm going to turn over to Dr. Beck, who is going to moderate our panel with Ruth Ann Norton, our keynote, and a couple of other folks. All right, over to you, Andy.
Well, thanks so much. And yes, it is good to see you again, Ruth Ann. I think the topics that you're presenting are really well suited to conversations we're having here in Cincinnati, and about how to, elevate the importance of healthy housing and green initiatives into the same conversation as, keeping kids healthy, keeping their families healthy, and maintaining healthy communities. And I think we have a couple additional really excellent panelists to help further our discussion. And I think what we'll do is I'll introduce each one, and after that introduction, give them a couple minutes to talk more about the work that they do, and then we'll come together for a discussion thereafter. I'd encourage anyone and everyone to put questions into the chat, either as it pertained to the keynote or to the two panelists that will be introduced in a moment. And hopefully we can have a nice conversation for this last half hour of our session. I'll provide just one word of warning for my own participation. I am actually on the inpatient service right now. And so if my video goes dark or something, it probably just means I have to answer a page. So my apologies for that in advance if it happens. But if we advance to the next slide, I believe our first panelist is Ms. Nina Creech. She is Senior Vice President with a focus on whole home and innovations for people working cooperatively, which is a really incredible organization here in town that I believe she'll tell us a bit more about, and then will be a wonderful addition to our panel. So Nina, if you want to come off mute and tell us a little bit more about yourself and your organization.
Yeah, thank you. So hi, I'm Nina Creech. I'm with People Working Cooperatively, and I'm just going to spend a few minutes just to give a quick overview of what we've been doing here at PwC. So for those of you that may know us, I'm just going to advance to the next slide. We have been around for 46 years, and our mission is to keep people safe and healthy at home so they can remain independent, living in a safe, sound environment. And there's a variety of different ways we do that, and I'll talk about that in a minute. Go to the next slide. Just to give you some quick fun facts about PwC. We are in 18 counties. Sometimes it goes up to 20, depending on funding. We're in Ohio, Kentucky, and Indiana. We provide emergency services. I have no heat. My toilet doesn't flush. And where you live in our service territory defines how that works. We average over 9,000 services a year. Just since we've started, I think we've just hit over 350,000 services. So we're serving a lot of people. We have an incredible volunteer corps. So PwC has about 120 paid licensed professionals. And on top of that, we are supplemented by a volunteer corps that goes in and helps us do additional work. We are boots on the ground. Our clients, we serve over 5,000 people a year, half of which are elderly. Typically, their income is about $13,500 a year, and more than a third of them have households with children under the age of 18. We'll go to the next slide. So very similar to listening to Ruth Ann, I'm smiling. I also started in 1993. So it must have been a big year in the social service world. And we came up with a whole house strategy where we combine our emergency services, our energy conservation services, and our modification services when we can together. And we've been doing this for successfully, I would say, for over 20 years, our whole house model. But it's very interesting, and I'll talk more about the research. You know, the payer often wants to define how we work. And when we were just in the housing space, our funders were focused on, tax base, code violations, all these different things that, but there's people living inside the house. So we also decided there needed to be a larger focus on people. And we kind of spun off 2 different new programs as part of PwC. So we started Whole Home probably about a decade ago, and that's a fee for service arm of our organization where people who were hovering above our income guidelines were asking for our specialty services such as modifications, aging in pace, lead, and they didn't always qualify for programs. So we set a table for them to be healthy there. And then we created our innovation center. Go to the next slide. So it was kind of an abstract concept, but the concept behind the innovation center was, we are always there after something occurs. We're never preventative. We're always an emergency occurred, or or the lead poisonings happened. What can we do to stay up front of it? And we tried to go from an organization that was transformational in the sense that we are not just a direct service provider, but we're part of a larger stakeholder group that shares a vision for keeping people safe and healthy. So we've, often our doors were to housing people or to DOE, but we weren't talking to health experts. And when we did, some magic began to happen for us. So I'm going to go to the next slide and give an example for what we're working on with the Innovation Center with I promise it's only a 1-minute video that kind of shows how a concept becomes a reality for us. We know the home and health relationship exists, and we know this based on years of experience. There were a lot of practices we were doing in terms of the remodeling and emergency home repairs and adaptations we were making, but there was an opportunity to do more. We became certified to teach Stepping On a couple years ago.
We talk about strength and balance, and a physical therapist shows us very simple exercises that we can do.
We target the large muscle groups that are important for balance recovery.
We also talk about your home environment, which of course is our specialty, but we talk about your vision, your medications. We have a pharmacist on our team.
So we tell people in our class, we are empowering you to live your best life at home.
And give them the knowledge they need and the tools in their arsenal to change their lives.
So that is just my quick commercial for our Aging in Place programs, but we picked 3 main areas that we were seeing, and the theme is the same amongst all of us. So we were seeing a lot of problems with lead paint. We were seeing a lot of problems with asthma, and we were seeing a lot of things for aging in place. So we tried to set up a space to have conversations, do more research, try to stay on front of things and introduce ourselves to new partners, kind of a convening space. And there's been some really positive outcomes since we started this. So I'm going to go to the next slide. So we focused on, we call it a showroom space, but within the Innovation Center, we have displays. This is my Stepping On display where we play a game, but we simulate what it looks like in a home and talk about the different features that people need to pay attention to. Education, when you combine it with the in-home intervention, the difference is huge. So often we're different folks talking about different things, but we're really working on bringing all the folks together. Talk a little bit about research. I would not be where we are right now without Stepping On and GHHI. So we began working with them and developing a sustainable financing model to scale up programs. And after that pilot, it turned into a demonstration project that we're doing with Molina. I'm also partnering with them on a HUD demonstration project where we're combining energy conservation work and lead work together. And I think, what I can't wait to learn what you're going to talk about with HUD and DOE, Ruth Ann, but these programs are complicated, they're complex. The administration is hard for the people who are receiving the services. We certainly don't make it easy on them. And just trying to streamline all the services, if we could do everything at one time to really serve that person, I think the outcomes will continue to grow and be bigger. I want to talk a little bit about I'll go to the next slide, on ways that we've tried to engage the community a little bit. So we are part of this group, and that's turned into some wonderful things through the medical students scholar class. We got together and they wanted to have their geriatric scholars programs meeting here. And we facilitated the meeting, and we got to meet Dr. Hamrick, who's the chief of geriatrics for both University Hospital and Veterans Hospital. And we talked about our plight, how at the point of care, referrals don't get made to organizations like ours. And together, through a grant, we came up with a project where we built a website that is embedded in Epic, and at the point of care, people could make the referral into an organization to serve people's needs on fall prevention work. just a little thing, but those little things together of us talking and facilitating and tying together, how do you bring the house into the health? And that's what we've been focused on doing. Next slide. So we talk about this as a convening space, a lab think tank. We facilitate a lot of meetings, hands-on experience. We work on product development. And there's a new product that we're launching. It's a virtual house, and it's at your.wholehome.org. And our hope there, we're focused on aging in place, but we've created a home that simulates all the different things that you have in your home, all the living spaces, and gives tips and advice and videos of what you can do to make your home safer. The idea being that once we get, once we launch this officially, we can add on to the home, and then we can talk about asthma, we can talk about lead, we can talk about a variety of different things. Those are the big three, but there's more work to do, and there's more ways that we could support families living safe and healthy at home. And go to the next slide. So what I hope today is to continue to make new friends and create new partnerships. And we can work together because we have an incredible opportunity to come together and improve the lives of people through their housing and health all at the same time. And it takes all of us. So I want to thank you for this opportunity to be on this panel. And if anyone has any questions, I'm ready for you.
That's great. Thanks so much for that. I've been taking some notes about some themes that I'd love to return to. And one of the themes is the kind of partnership between sectors, organizations, et cetera. And so I wonder, before we get to some specific questions, if we advance to the next, we'll introduce Nick Newman. And I highlighted one of the themes because I noticed on your the background picture with the CTSA slide was really wonderful because it included both you and Dr. Newman on the slide. So I think it highlights this degree of partnership and potential for more impact when we bring these sectors into more cohesive alignment. Nick, I'll have you introduce yourself and provide a little bit of background about the work that you do. Dr. Newman is at Children's as well as the University of Cincinnati College of Medicine. He leads our community engagement core for the Center of Environmental Genetics, leads our environmental health and lead clinic, and is also a site director for our pediatric environmental health specialty unit. He is our go-to for all questions environmental health at Children's, and happily is my office neighbor next door to me in our general pediatrics offices. So Nick, take it away.
Oh, thanks so much. And Ruth Ann Norton, thanks so much for participating in this. I've followed your work for a long time, and it's really been wonderful what you've been able to achieve. I don't have any additional slides. I'm just going to briefly discuss maybe what these different things are and how I've partnered with different groups. So, I think my clinical work is focused around taking care of children exposed to various environmental toxicants, and lead being the most prevalent one. But other things come up, particularly around indoor air quality. And this all intersects with poor housing often, or poorly maintained housing, and other social influences on health. And, for people to understand like what all these different like things up on my slide are. So, our community engagement core over at UC is basically set up to try to work with and engage with communities to try to bring what we know about environmental health to people, and to feed that what people are both interested in or concerned about back to our scientists at UC, so that we can help to better translate research into action, but then also inform research based on what's actually going on. Pediatric Environmental Health Specialty Unit is part of a network of centers that are funded through the CDC and EPA to provide expertise in environmental health for children. And I've been involved with that for a number of years. And, I think ultimately a lot of the core of what I'm trying to do is to translate what's known about environmental health, what we've learned from our research, into actually something actionable. And so, I see this in my clinical work all the time, particularly with lead. And I think, what is impressed upon me as a clinician is that a lot of the solutions are not going to occur within my clinic or even my purview, but I can use my knowledge and connection to families and to other groups to try to make things happen. So for instance, the clinic actually has public health nurses embedded in it. So we're able to provide a really nice, warm handoff between both, ourselves and the local public health agency. And, I think one of the things the last thing I really would like to talk about is the partnership development grant that people working cooperatively and Children's Hospital started a couple of years ago. And, unfortunately, right as we were about to go live with this project, which was to connect children with difficult to control asthma to comprehensive home repair and inspection services through PwC, this, was finally given the okay by our IRB the day before everything locked down for COVID. And so it's been an interesting kind of learning journey, but I think one of the most important things really is how important it is to bring these different people together. And Ruth Ann, it's really heartening for me to see how you've been working with Priority Health and West Michigan Healthy Homes Coalition. I met all of them almost 20 years ago, and they're really a great model as to how to operationalize some of these things. And but I think the program with PwC I think is great because they have PwC has as you've seen a great variety of services that they provide, and they're also been really helpful in terms of being flexible, because as we discovered, one of our barriers here is that a lot of people live in rental housing, which is often difficult to be addressed through their granting mechanisms. But it looks like there's been some changes there, so we should be able to get more done. But that's about all I have to say. I really want to make sure that other people have time to talk. So all right, thanks so much. I'll just mute for a minute.
All right, thank you, Nick. So yeah, I think to me, what is really interesting, and I feel like the pandemic has put this into even a fuller view of the need and benefit for meaningful partnership across sectors and organizations. And I've heard that in each of what you've described at the federal level of what does it mean for DOE, HHS, HUD, CMMI to be working together, but also at our city level, what does it mean for PwC, our health departments, our the public sector, our hospital, to be coming together in these stakeholder groups, Nina, that you described. I'm just wondering if perhaps any or all of you have some comment on ways we can continue to push toward that reality where we're not just separating off efforts, but we're identifying ways to partner more effectively and enhance what we all can bring to the table. So I don't know, Ruth Ann, if you want to start with that question. And I think you're on mute.
There you go.
There you
Sorry. Well, won't be glad when this pandemic is over. We no longer hear you're on mute. And Nick, so nice to connect. And Nina, what a great, I mean, the work PwC is doing, we are so happy to be partnering and working together. And we are trying to take the complex and make it simple on the facing end for families. But I think, Dr. Beck, one of the biggest things that we've been able to lay out as we are starting now to roll on larger hospital community benefit investments, managed care, CHIP, right? And these other opportunities is really, number one, assuring healthcare that we are working with them to build the evidence-based practices and the reliability of service providers. Like PwC is an excellent example. There's got to be really strong build in the service provision side. So in New York, right, where they mandated this and other places, it's a critical thing to do. But what we've been able to lay out is a shared gain in this, right? And so as I was talking yesterday to our largest health system in Maryland about putting $100 million in, and the real legacy that is a tipping point investment, that $100 million, if it comes through, will bring in shared investment of $900 million. So it will be $1 billion project, right? And the health leading with healthcare is so critically important. I think it is important to have a consistent learning network that is working together toward a shared goal that has a discipline that includes utilities, that includes your banks through community reinvestment. Banks, every major bank institution in the country, and in Ohio, you're looking at Huntington and Fifth Third and PNC and others, right? But they all now have at the heart of their community reinvestment dollars, housing stabilization, health and equity, right? Outcomes, long-term earnings. So they have to be at the table with hospitals, with Medicaid managed care. It's really incumbent upon service providers in dealing with the Medicaid managed care organizations who are on a fast track on social determinants of health. So whether it's Molina that we're talking to, or Anthem, or United, or Blue Cross in North Carolina, right? Who are all looking at specific things that are priorities, age in place, trip and fall, or asthma rise to the top, that we understand their needs and we can translate them into service, and to understand that it may not be everything you want today. Anthem has been amazing, and AmeriGroup's been an amazing partner, but we would have loved for them at the start to immediately go forward. And I'm going to be really quick here and go offline. My battery is dying for some reason. I got to figure out why we're not plugged in. But I think that's the conversation. But in Detroit, for example, Detroit Energy has $15 million a year they spend on home improvement, and sitting down at the table and saying to them, okay, align with the work that ProMedica, Henry Ford, and 8 housing providers are doing, being able to map the alignment and what the outcomes are, and then bring in the feds, become an important value. Let me fix this problem, and we hear from others.
Sounds good. Nina, I'd love your thoughts on this. And you know, that you mentioned, I think you used the term like magic when some of these sectors come together. I'd love for you to talk a little bit more about that.
Well, I wish I had more magic, but I do think, you know, there's so many locally, we are so closely aligned on what the community needs, like how we can make this better for people. I do think what's missing a little bit is we need to have more people that are being served involved in the conversation, instead of us, here's what you need, what do you need? And so we're hoping to engage more, more people to talk about those things. What's hard is what we're often talking about is an abstract concept, the fact that there is that relationship between the physical structure that you're living in and the health. And then often when you do any kind of remediation work, it's invisible. It's not as if, we clean up mold and wow, it looks like a new house. It still is a housing stock that probably needs more work. So I think it's going to take a lot of different layers of education to engage people and talk about how important it is. One of the things I know we would like to see is when you talk about housing as a part of the pie for the social determinants of health, our piece of the pie should be far larger than it is. It's just a tiny little piece. And I feel that for the impacts that we could make, it should be larger. And I think if it was, maybe we could engage more stakeholders. So I think, every stakeholder, and I go back to 20 years ago, you'd be talking to a funder and they were worried about the structure. We were talking about the house. We weren't talking about the person in the house. Now we're talking about both. And we're talking about how do we combine it and help people live longer. And years ago, probably I think 10, 15 years ago, after we completed a study through a DOE project we were doing, we learned that we were impacting health, education, people were, housing values were selling, like it was like a gold mine of data, but nobody was really interested in hearing it. And I'm sure Ruth Ann can speak to that. I mean, some of these things have been known. What is the magic that it's going to take to make that really get people's attention? Because I think if all these programs were aligned and coordinated and we had the workforce built to go, oh my goodness, what we could do. But everyone isn't there.
Well, Nina, I think it's a couple of things, right? One is we continue to embed it into federal policy as guidance. So what you are seeing in the grant that you have from HUD, right, is the directive to align weatherization and lead programs together. And actually, they're giving you $1 million to do that, right? And to bring that coordination. So that was, that's something that was modeled after the GHHI work with HUD, but it's one way to do it. Looking at the DOE and HUD now saying they will cross-qualify is also a directive that then comes down to the state agencies and comes down further. But I tell people that in the 10 years, right, that we have been really focused on this alignment work, we're actually now starting to see this move much faster. There's not a Medicaid managed care or a health system that we talk to at all that isn't focused on how do they put money into either trip and fall, asthma, lead, and now moving super quickly is the energy efficiency and climate work. So we're about to announce an HSI CHIP program that we are involved in that's for expansion to include those climate measures, right? Energy efficiency, decarbonization as health measures there. It takes time to see getting people to go, right? So part of what we've tried to be is the people who get at least big institutions to a yes, to build the model. But it took 10 years of feasibility studies, of economic analysis with what healthcare trusted and what government trusted. So we lined up our horses with Milliman, for example, on actuarial analysis, because they are so influential in medical payment models. And we learned and built some with them. Medicaid directors throughout the country understand this. I walked into Kate McAvoy's office in Connecticut, and where she said, you don't have to prove to me that it works. You have to show me how to do it. So I think everybody is learning on both sides. In California, they now will reimburse $7,500 for asthmatic patients for housing intervention, up to $7,500 on what's called in lieu of services. It's the in the weeds in Medicaid. We wrote a paper 5 years ago mapping out this pathway in lieu of, and every Medicaid expert in the country told us we were crazy. Well, we're happy to be crazy when the state of California adopts it as a measure. California doing that opens the door to other states. So I think it's building on each other's models. I think that's the answer. I know we're getting the hook here, it looks like.
Well, so yes, we are cognizant of the clock, but this is a really important conversation, and I'm thankful to each of you. I'm just happy I've been even a brief part of it. I mean, some of the common themes that I'm hearing are the need for cross-sector work, the need for meaningful community engagement and code design of intervention, the alignment of goals and alignment of measures that can be then tracked over time and shared for standards that cross the board from federal on down to local.
Yeah, I think Dr. The reality is we have always said the community should be listened to. If you are not actually documenting and really listening to community at this point, you're failing the goals of health and racial equity. And that is becoming very important in the decisions that are being made by elected officials and agencies and state governments and all. I think the ROI analysis that has been put out across the country, in which PwC and you and Nick are contributing so greatly to. But sometimes I have to give one bit of advice. Do not fail to ask. And I think, and this is not, I'm not talking about PwC or Cincinnati Children's or even GHHI. We're all not sitting back waiting for somebody to come and show up and give us the, all the gifts in Santa's bag, regardless of season. But, it took a little bit of guts for us to sit down with a major health system and say, we want $100 million of your money, and here's what we need you to do. And here's why it improves your legacy in our community and why it improves your goals. And I learned this a long time ago when I asked the governor of Maryland, Paris Glendenning, for $50 million on lead and got every dime of that in new money. And as I walked out of the room, he said to me, well, we were willing to go to 80 million. And it was like, ask for what you need, not for what you think you will get.
That's good advice.
Good advice.
All right, Lori, I'm going to turn it over to you.
Thank you. Thanks to all of our panelists. That was an incredible discussion. Thank you to Ruth Ann Norton. We're excited that you were able to come and spend this time with us. I just want to have a couple of closing remarks. Today's presentation really reminded us of that intersection of housing and health, and how housing is absolutely essential to our wealth, to our community, and to our health. When we allow racial disparity and institutional inequity to affect housing, no one wins. Although there's no one size fits all solution to challenges facing our cities or to the housing crisis, we have to come together to find a toolbox of solutions that work across sectors. And we must persist in this work until injustice is eradicated and all individuals have safe and affordable housing. So I just wanted to end with those words. We have some great things, some websites and links that we will send to you after. We will also send you an evaluation of the program. Thank you so much for spending your lunchtime with us today to talk about this very important topic. Feel free to join the CCTST if you haven't already. We encourage you to do so, and thank you, and have a good afternoon.
Thank you.